really.
Yeah.
We should get
True.
started.
Yes.
Welcome, everyone, to the monthly CMDA meeting, February. We're glad to see everyone. Oh, there's Chad. I think we're going to start with a special announcement from our president, Sing Hallett, regarding our upcoming annual conference.
Oh, great. Thank you. Yeah, let me see if I can just share with everyone. We would like to invite all of you, plus all of your friends and colleagues, to join us at the CMDA annual conference. It's going to be on Friday, April 25th. It's right here in Denver. It is an in-person conference, and you can register right now if you want to. What I'd like to show you is the registration website and the agenda for the conference. If you go to our website, cmda.us, it'll take you right to the main page where we are featuring the annual conference at the very start of the website. From here, you can look at the agenda and you can register either as a participant or if you want to exhibit. For today, I'm going to pull up the conference schedule just to show you what it looks like and to give you a preview of what's to come. Usually I'm able to just see the conference schedule right here. Oh, here it is. It's coming up right now. So if you go onto the website, you'll see who's going to be speaking on April 25th. And we'll start with some information about Alzheimer's disease biomarkers. We'll talk about anticoagulation. And we have a very exciting keynote speaker, Dr. Ann Basting, who talks about finding joy and finding innovative ways to communicate with people who have dementia, specifically in long-term care settings. We'll talk about benzodiazepines, medication errors. Jenny Albertson is going to talk about partnering through regulatory change. And Dr. Lin will talk about value-based care. The afternoon, we'll have a presentation by the CDPHE, a panel discussion on medical marijuana in long-term care settings, early identification of sepsis, the Cam-Ducky Derby, of course, and seizure management in the nursing home. It's pretty exciting, and our speakers are fabulous. So I hope that you will all take the time to register, go to cmda.us, and join us for the conference on April 25th.
Great. Thank you, Sing. I think we'll move into updates now. And I think I think I saw Chad here with CDPHE, if you'd like to give your updates.
All right. So hello, everybody. Just a quick update for the section. We're working on, right now, staff development. Over half of our surveyors have less than, 18 months of experience. So we're focusing on that. There's been a high number of complaints and facility reported incidents that we're trying to process and to be able to manage that part of our workload, we've prioritized uh, we've prioritized that for ourselves, understanding that the facilities may be reporting timely, but if we're not able to process in a timely fashion, it might mean that we're going to be out in your facilities later than expected. The the unfortunate drawback, the outcome to all of that is if there is a citation of deficient practice, current deficient practice that may be established, that the incident, the event was several months ago. Well, and we want to be able to make sure that our visits then are timely, so that you're not looking at several months of perhaps enforcement because of the delay in being able to process all of these complaints and facility reported incidents. I did want to talk just briefly. You may have experienced or you may have heard that, we're one of the states that really, I think, places a high value on alternate enforcement remedies. So the first layer of enforcement remedies is we're going to fine you. You're going to get fined. Um, and I don't always know that that is the best way to change practices. And there's other assorted whether it's a by instance or whether it's a daily fine, or if the delay in returning to compliance is such, there could be a denial for payment for new admissions. And I don't know that there is a lot of research behind whether that's going to change practices or not. It seems to be the preferred method across the United States, but we do look at alternate enforcement remedies. These are things like directed in service, where we may ask the facility to bring in a specialist, do an education, and then have some sort of a proficiency or a return demonstration or an assessment to make sure that folks are understanding the information that's being provided. Directed plans of correction, you probably see most often. I think we've had an increase over the last several years of using directed in service. Directed plans of correction they take time. Most of them ask for some sort of report back from the program, us, the program approved um, state agency, and we approve the person doing the both the directed in service and the doing the consulting for the directed plan of correction. We look at these for repeat citations at harm or higher, where prior efforts have not been sustained, and we get reports from the consultants. Essentially, we're going to be looking at 12 weeks of weekly reports, followed by 3 months of monthly reports, and then that ends with program permission. And what I like to see is some sort of transition or handoff so that we can accomplish that. Rather than just, well, we've got a hard date here and now we're going to go our separate ways. I don't know that that's conducive to producing change. State monitoring, where we might have our own surveyors come into the building. We're required to do state monitoring if there are 3 consecutive substandard quality of care situations. We'll build a plan around how often we're going to go in, what we're going to be working on with the facility, and determine the duration. And again, so state monitoring, we're not going in and we're not looking to identify new deficient practice. If harm does occur or something more significant than harm, then we're going to have that conversation. And we can cite, but that's not the intent of our visit. The intent of our visit is to be there supportively, working through issues, recognizing the facility's good faith effort to self-identify and correct issues as they come up. So really reinforcing, fortifying good, solid processes, particularly involving quality assurance and performance improvement. Temporary management is another enforcement remedy, and we usually see these when there is persistent or catastrophic noncompliance. And so this is kind of a um, I won't say a last resort, but it is kind of moving further and further down the line of needing to make some changes. The temporary manager has the ability to correct deficiencies, oversee that correction, um, hire, fire, um, alter facility procedures, and obligate facility funds. We look for a high touch to a low touch situation in these when we have temporary management in place, and we have a rubric that we follow in terms of the removal of temporary management. We've just had some situations lately where we're seeing more of these kinds of strategies, and I really just wanted to bring to the group today just a quick oversight over the types of alternate enforcement remedies that we have in case you see some of these, I'm sure not in your facilities, but if you hear them in other facilities, you'll have some familiarity with that. Thank you.
Chris, I
Thanks,
think
Chad.
you
I think we'll move down the list to Jenny Albertson with CHCA updates. Thanks.
Right. I've just got a couple of slides here, but they're sort of hefty, so bear with me. There's a lot of information popping out, as I'm sure you're well aware in the media. So I'm just going to hit a couple of high points that are of pertinence to all of us. So first off, I'm assuming that most of you know this already because you've probably clicked on a CDC site in the last couple of weeks. There's a freeze on government agency communication, particularly public health communication. The Trump administration executive order stated pause all external communications such as health advisories, weekly scientific reports, updates to websites, and social media posts. So you may get a picture like this when you look for data. In fact, I tried to click on our local public health COVID data this morning and still received an error there. So what you're seeing partly is a reaction to the executive order that demanded that all agencies remove woke language from their nomenclature. So for example, you're going to see, instead of a pregnant person, you will now see a pregnant woman on the way that people are articulating things. This just takes a lot of scrubbing for them to clean up the language and bring it into compliance with what the administration is expecting in order to get the green light to repost. So there is not a blanket release of this as we anticipated by February 1st. They are still pushing this out and there is no estimated date for re-release. Some tools might look like they have data, but it is most likely incorrect or outdated data. So please tread lightly as you pull information. If you want a link on this, I'll be sending these slides to Chris and Singh, so you can have the link to the McKnight's article. Also with this is a delay in our 5-star ratings. So if you're looking forward to seeing something pop in a positive direction, you're going to have to wait for your facility to look like it has an improved 5-star rating. What they did is with Care Compare, the scheduled release was January 29th, and they froze this along with all other health agency reports because it is a consumer facing resource. It is considered a public exposed announcement or post. This release of Care Compare was going to include an unfreezing of several items, quality measures that were 4 quality measures that they suspended while they made changes to the MDS a year ago. So they're also going to include payroll-based journal data for staffing through the 3rd quarter of 2024 and health inspection data that, of course, has rolled out from the results of Chad's work. All of that is not updated in the system. So if you're looking at 5-star, it is delayed. It is not accurate either. CMS also in the last little while did release their mission and priorities. Apparently this either came under the wire or it's permitted because of the category. I'm not exactly sure, but they did announce that they concluded all of their rollout of facility assessment changes, enhanced barrier precautions, and the updates to the surveyor guidance, which they did update yet again and pushed out the release to March 24th instead of February 24th. So they added a little bit more surveyor guidance on how to evaluate staffing, particularly, and like what to do if for scope and severity citations if a building doesn't have a DON or something like that. But they did announce that they have new focus areas for fiscal year 2025. They are going to continue to focus on reducing the usage of inappropriate antipsychotics. The way they explain it is that they are still seeing so much information come out about the inappropriate use of the diagnosis for schizophrenia and so forth that they believe they can't take their eye off the ball on this one, even though we've put a lot of years behind it, as we all know. Preventing discharges that violate federal requirements is going to also be a pretty significant focus. This is also a really big area of focus on the assisted living side. So if you contribute to the medical direction at a continuum of care community, all assisted living involuntary discharges are automatically being routed through their incident reporting system as a complaint. So you're going to see a massive increase in complaint activity on the AL side for all involuntary discharges. They're also focusing more on nurse staffing requirements and PBJ reporting compliance, which is why they added that additional language in the survey guidance. On the good news side, they are continuing to test the risk-based survey model, which would allow us to kind of get good behavior recognition for buildings that are routinely good performers on the survey activity, and then allow them to have kind of an abbreviated survey. This is not rolled out yet, but it is supposed to be a streamlined process that still gets at the ensuring of compliance. We're expecting that to roll out in the coming year. There are pilots in some states already. And then I just wanted to summarize the national news that does have an immediate impact on senior care. I put them in bold here. So tariffs are definitely going to have an impact on senior care. The China tariff did go through, and that impacts our pharmaceutical production. So even generics that are typically cheaper may not be so cheap in the near future. So be aware that you may see some cost increases, and some of the things that we've been fighting for under Medicare to reduce costs, we may be backpedaling on, I don't know. And then Mexico is one of our primary suppliers for medical devices. So things like nebulizers, oxygen sensors, catheters, disposable surgical tools, all those things, wound debridement supplies, will see an increase in cost for us. And there is currently no exception for healthcare related products, nor is there one to be expected. RFK Jr. is also likely to be approved for the HHS position, and that will bring with it an anticipated reduction in both immunization approval timing, as well as promotion of it. We expect decreased volume of vaccination among children, elders, our entire population, and therefore an increase in risk to all of us for endemic diseases. We're already seeing some measles outbreaks that have not been publicly reported because of the lack of public agency communication devices. So there's also in Kansas, which is of course kind of close, some TB that we're seeing spike there. That is beyond what we've seen in their history, recent history. Medicaid funding is also likely to be on the chopping block. They're looking at tying it to work programs and having to prove that you qualify for Medicaid, not just based on income, but based on working. So for our patients that are under 65, we may see that infringe upon their immediate approval for Medicaid. And also we're expecting them to look at reducing Medicaid funding match at the federal level, which would then reduce our state funding because of the incredible dollar amount that we see in senior care. So nursing home care increased 13.4% again over the past 18 months. So it's going to draw attention of legislators as a potential coffers to get their funding for other things that they would rather be funded. And then also on a positive note, we have upcoming training opportunities. You'll notice when you go to our event calendar that you're going to see these little insignias, these little circles that say whether something is for both assisted living and skilled nursing, or it is just one or the other. So do note that there are some things that are broadly accessible to your other partners if you do support ALs. So thank you very much.
Thank you, Jenny. And our next update will be from Telligen with Mariah. And I think Mariah is muted.
Thank you. Are you able to see my screen okay?
Yes, we are. Thank you.
Wonderful. So I just wanted to share a couple of Telligen updates. So right here is a graph that is focused on our COVID-19 vaccinations. We still, with our extension, we still receive referrals for COVID-19 outbreaks and to support nursing homes with vaccination uptake. And so this graph demonstrates the average resident COVID-19 vaccination rate homes that were referred to us by CMS in our region. At the time of referral, these 209 homes had a vaccination rate of 0%. And so after 9 weeks of collaboration and technical assistance, the average rate increased to 38%, which was close to the national average of 40% on January 12th. The national average for resident COVID-19 vaccination rates in November, which was when our nursing homes were referred to us, was at 27%. So they had quite a bit of catching up to do, and we're able to catch up through using a couple of interventions. We saw a couple of consistent patterns where we were sharing information on motivational interviewing techniques to facilitate discussions on vaccines for residents and their staff, working with leadership engagement and having consistent messaging. Um, Support with NHSN reporting, where to find those accurate vaccine information, and through our vaccine clinic partners, where we're able to identify many pharmacies and other programs like the Front Range Area Health Education Center, who is working with CDPHE, in which we learned about through CHCA. So thank you, Jenny. And so if they ever needed those vaccine services, they were able to establish that relationship for that immediate need and then for future needs as well. And then here I'm just sharing some of the data, Colorado specific data for the pneumonia vaccination. So right here we're sitting at 90, about 90%, whereas the US average was 93. And then over here for influenza, where we were sitting at 93, about 94%, and then the US average being about 95%. And then lastly, I wanted to share just a really unique intervention. We had one of our facilities implementing to kind of make education fun and for their staff immunization uptake. And so the infection preventionist had shared with us that prior to her taking her role, their flu vaccination rates for staff were about 45%. So she had set an internal goal to increase the uptake by 10% to kind of keep it reachable. And so she had scheduled clinics, posted the signage, and about 5 days before the clinic, she initiated using these flu clothespins. And so what she did, on them, it says, "You've been infected with the flu," right here. And then it says, "Go infect someone else." And so she had put a couple of clothespins on some of her staff members and then went back to her office, and she has some cameras to be able to see the hallways. And so she kind of got to see the game unfold and go into effect. And so about an hour later, she had announced over their intercom for all of the staff that had been infected with the flu to go to the dining room. And so she gave everyone, she called them fast flu facts, and explained how quickly the flu spread, and then just kind of talked about the upcoming clinic that they had. And so they hosted their clinics during the working hours. And every single staff member had an appointment with her, the infection preventionist. And in the appointment, they either received the flu vaccine or they signed, a declination. And then so through this intervention that she had implemented, they increased their staff influenza vaccination rates to 86%. And then she also uses these two pictures right here, this yellow one, and there she just calls them her pathogens or her germs. The yellow one is supposed to be the rhinovirus, and so she attaches just facts based on whatever pathogen she has put out, and says, "I can live on hard surfaces for 24 hours," and she'll put these on places that are high touch surface areas or on nursing carts, staff break rooms, and mainly in the staffing areas. They're big enough to be noticed, but small enough so they're not intrusive, and did not put it in any resident care areas. And she just mentioned again how important it was to change whatever was being posted out. So then she used these little green guys that she called them her snack germs. And so these she had facts about the chain of infection. And so they would just have funny sayings like, "Will you be my susceptible host?" Or, "Hey, sanitizer isn't important. I want to hang out with you," or kind of things like that to just to keep that in the forefront of her staff's minds as they're going through their day. And then lastly, I just had our our extension menu of services. So right now, our technical assistance is focused on COVID-19 infection prevention and control, and we continue to have that nursing home quality essentials webinar, which is on Tuesdays and Thursdays, and I put it in the chat. I can put it in again, but Dr. Gom, we have the pleasure of having Dr. Gom present on navigating the evolving landscape of COVID-19 and influenza in long-term care with our pharmacist Megan. So we're very excited about that. And then here is just our Telligen Colorado team. Our extension right now goes to oh my gosh, March 7th. And we're hoping to hear who will be who will be awarded the next scope of work. So thank you guys, and I will hand it back over.
All right. Thank you, Mariah. Thanks everyone for your updates. And now it's my pleasure to introduce our immediate past president, Leslie Eber, is going to give a talk on managing pain.
Thank you so much, Chris. Thank you, everybody. So great to be here, and what great updates. I've already learned a lot, so thank you all for your updates. So this is going to be a quick review of a big topic, treating pain in post-acute and long-term care, balancing treatment and safety, which is a trick that we're all trying to do every day. Oh, hold on a second here. Okay. So I'm just going to make sure I can see my own slides. So our objectives today to discuss common types of pain in post-acute and long-term care patients, identify non-pharmacological alternatives to pain management. Do they work? Are they worthwhile? Discuss options for non-opiate treatments of pain, and identify strategies to use opiate pain medications safely. And finally, even though it's a very big topic, we're going to touch upon opiate use disorder and how to treat it. Okay. So first, let's frame the conversation and know that many of our patients are struggling with pain, and we may not really realize that. So 25 to 50% of community dwelling older adults have pain, but in our setting, it can be up to 80% of our patients that are struggling with pain. It's not a little thing, it's a big thing. And so it's an opportunity to really affect the quality of our patient's life.
Hi, my name is Erica. I'm a nurse practitioner at Landmark Health Park United Healthcare.
Oh, sorry about that. So why is pain treatment such a challenge? And from the patient side, patients may really minimize their symptoms, may think it's just a part of aging, which is of course not true. Or they may not be able to express what they're feeling because of cognitive impairments. They also may have a fear factor of, oh gosh, if I say something to my provider, then they're going to start oxycodone and then I'll be addicted. And so there's a lot of barriers to patients communicating pain issues with us. But on the clinician side, we also have challenges. Sometimes we have a long list of things we want to talk to about our patients, and pain that may not be on our list. So we want to address their diabetes, their congestive heart failure, but I want us to encourage to ask our patients about pain. And we may go in with a bias, thinking that, gosh, if I ask my patient about pain, they're going to ask for an opiate, and then that's going to be another challenge. And so we may have some reluctantness. And we not always knowing that pain is really an issue with our patients who are struggling with cognitive impairment. We may just see their behaviors and not really realize or even consider that pain is behind those behaviors. And so it's really important to go down that road of exploration. I really like this quote from Dr. Sarvin Takoda. It was just published in 2024 about our shift in looking at pain. So the focus has shifted from this binary yes or no approach to having pain to a nuanced understanding of pain management that really emphasizes individual care. So sometimes people may be uncomfortable, not consider it pain, but really we want to invest in that relationship and understand those nuances of pain control. I always believe it's good to have a plan. Always a person with a plan. And this is a strategy that you can use to address pain in your patients. And for me, it kind of keeps me honest to do the things that I know will be useful and have less side effects. So first of all, set realistic expectations for pain management. If you've been an 11 out of 10 pain for the past couple of years, my chance of getting you to 1 out of 10 pain this week is really not a realistic expectation. Then you really want to try non-pharmacological approaches to pain, and we're going to talk about that. I move to then some topical drug therapies for consideration, diclofenac, capsaicin. These are topical medications that are really useful, and we sometimes forget about them. When considering adding a systemic medication, I always also consider deprescribing at the same time. And then thinking about those drug-drug interactions. And so if I'm going to use, we were just talking about this previously, an NSAID for a short amount of time, I want to also realize if the person is on Eliquis plus aspirin plus an SSRI, these are things I want to be mindful of. When I start a medication trial, I want to educate the patient and the family that this is our first go round and we're going to see what works for them. I start low and go slow and monitor for side effects. And I have really clear endpoints. And I think this is really important. Sometimes we start a medication and the person kind of feels better, but we're not sure. I think it's important to set our expectations about how we're going to decide if a pain medication is working. If it's ineffective, please don't leave it on. I think that happens a lot with gabapentin and Lyrica. We just leave it on. If it's not working, let's stop it or taper it off. And then discuss with patients that may take a few trials to see what works. For opiates, if I'm going to start an opiate, I talk about how I'm going to stop it and taper it when I start it so that everybody's on the same page. So I love this CDC PEG score. It's like one of my favorite things. And it talks about how to talk about pain. I think how we frame our pain discussion is really useful. And it talks about best describes your pain over the past week, not at this moment. Talking about 0 to 10, describe how during the last week pain interfered with your enjoyment of life. And we can flip that also and say, gosh, when you came here, I remember after your hip fracture that you were having trouble getting to the bathroom and you couldn't go out to lunch with your daughter. But I see this week, now you can walk to the dining room and you were able to go out to lunch with your daughter. That's amazing. And even if your pain is still a 5 or 6, we are getting there. And framing that conversation is really helpful. And then finally, talking about how your pain has interfered with your general activity and looking for those wins so that when people are in our SNF units, what can they achieve this week that they couldn't achieve last week? And so even though we're working on the pain, you are doing so much more. Okay. I also just wanted to bring up that there are a few studies that talk about social determinants of health and pain treatment, and that racial biases have really impacted how we can sometimes undertreat pain in certain patient populations. I think it's really imperative that we think about that and consider that. Clinicians should be aware of the impact of the biases in evaluating patients with pain and what do we bring to the table and to ensure that we are addressing everyone's pain with equality. Okay. So what about non-pharmacological interventions? People kind of sometimes think, oh, is it really worth it? Is it going to do anything at all? Should I try it? Yes, you should try it. There are a few negative side effects. There's added health benefits. There's low cost, no drug interactions, and it can also address other things like depression. So what are our options for non-pharmacological pain interventions? Definitely physical activity is a win. The data for Tai Chi is overwhelming. It can really not only address pain and movement, but increase quality of life and decrease depression, decrease falls. It's a win-win. Walking programs, group exercise activities, these are all incredibly effective for pain. And we don't usually always think about considering these things. Physical and occupational therapy is a great win for pain. And then even for our bedbound patients, frequent positioning and writing orders and partnering with frontline staff to make sure this is happening. Passive range of motion and gentle massage. Cognitive behavioral therapy is effective for pain as well as for stress and coping strategies. And we know that socialization is actually very effective for pain. So going to a ball game or going on an outing is really effective for people concentrating on something else than sitting and thinking about pain. TENS units is also effective. Okay, what about those topical pain medications? What should we consider? Diclofenac is really effective for pain, as is high-dose capsaicin. So don't forget to try these. They're really effective. So what about lidocaine patches? There's really very limited to no evidence that lidocaine patches really help. But I always actually in the past 4 years have had 1 or 2 patients, older women who put on their lidocaine patch and they grab their walker and they go to bingo and they go everywhere. And when I stop the patch, they sat in bed and they didn't get out of their bed at all. If that is the scenario, consider keeping the lidocaine patch. All right. So what are our non-opiate choices? People really often don't think about acetaminophen as an option or as a worthwhile option, but it's great first-line therapy. So there have been some data recently that shows that acetaminophen can be associated with some side effects that we don't usually think about, like GI bleeds, but it's still one of the safest first-line choices that we have. It's great for musculoskeletal pain, osteoarthritic pain. Dosing 3 grams in 24 hours is the maximum for our patient population, and we want to make sure to reduce that dose if you have liver disease and make sure we're doing renal dosing as well. Something we can do is we can schedule it. Maybe it's 1,000 milligrams 3 times a day scheduled, and all of a sudden people are getting up and they're walking and they're more comfortable, and it really does make a difference. For our patients struggling with cognitive impairment, as Leah Watson always reminds us, consider pain. And one of the things we can do with folks who are having behaviors is schedule Tylenol. And that is an intervention that may be incredibly useful. Don't forget when you're adding up all your acetaminophen dosing to consider what people are taking over the counter, as it often has acetaminophen in it. So what about NSAIDs? They're really high risk. They're not our first choice. If you are going to use them, the way I use them is a low dose, a low risk NSAID like ibuprofen, 200 to 400 milligrams, BID, TID with food, and I always have a stop date. I'm a 3 to 5 day person, so I really feel like that is something we can use to address pain, but not long-term care. It's for mild to moderate pain. And why are we so nervous about NSAIDs? The list is long. There's renal dysfunction, GI bleeding, platelet dysfunction, and we often forget it can also affect hypertension control and heart failure. One of the things that we can consider is if someone's having a heart failure exacerbation, did they just start on naproxen? Something we should consider. FDA cautions us to use ibuprofen with aspirin, and that's really not a good combination. And we also have to be careful for COX-2 inhibitors with our older population and increase in cardiovascular risk. So what about NSAIDs and starting a PPI? What is the data there? So let's take a look. I have to thank Dr. Singh Pallet for sharing this awesome table with me, and I put the reference below. But again, these are for situations when you're trying to use NSAIDs for a longer period of time. We usually see, you can see the NSAID side effects, especially GI side effects, even 7 to 10 days out when you're starting that NSAID. But if you are trying to use it for longer than 3 to 5 days, and I don't recommend that you use it for longer than 3 to 5 days, always have a stop date. These are the situations when you should add a PPI. And PPIs are more effective to prevent GI side effects from NSAIDs than H2 blockers. So we should know that. The risk factors we're looking for is a prior bleeding ulcer, older than 65, using high-dose NSAIDs or for a longer period of time, or concurrent use of aspirin, steroids, or anticoagulation. So I love this chart, and I'm going to keep it in my back pocket. What other choices do we have for non-opiate pain management? So they did this great study of antidepressants and found, which antidepressant would also help with pain, and duloxetine was the clear winner. And so you can think about that for neuropathic pain, and it can have some benefits. So what about gabapentinoids? I feel that we had a lot of issues with opiates, and then everybody switched to gabapentin and Lyrica, and really that didn't work. So gabapentin and Lyrica are not that great at treating pain. So people add them on, leave them on, but the person is really not reaping the benefit of pain control. So that's our first question. Is it working? Really, with gabapentin and Lyrica, just about at the maximum 50% effective, not very effective. Lyrica is a little more effective for neuropathic pain, postherpetic neuropathies, but really they're not that great. And they have a lot of side effects and risks. I'm sure many of you saw that article that associated gabapentin with risk of hip fractures. Of course, it has a risk of somnolence, dizziness, confusion, falls, mental cloudiness. One of the things that we often don't think about with the side effect with gabapentinoids is lower extremity edema. That's really common. So if you have folks who are struggling with that or struggling with heart failure, again, gabapentinoids are not your friend. One of the things we see is if it's not working, people increase the doses. And then we see patients who are on 1,200 milligrams 3 times a day. The first thing I think about when I see that is it must not be working. Most of my patients, when we taper off the gabapentinoids, they notice nothing. And so it's something to consider. We can also consider steroid injections for knee osteoarthritis, botulinum toxin injections for migraines and bladder spasticity. More risky medications is tricyclic antidepressants, and I don't use them for pain. The risk is just too high. And then less effective are alpha-2 adrenergic agonists. That was all a mouthful, wasn't it? So what about factors to consider when we are considering prescribing opiates for pain? What should we think about? And first of all, it should never be for mild pain, only moderate to severe pain. And this is a sentence that I'm going to say over and over. There is no evidence that long-term opiate use improves pain or function. There is no evidence that long-term opiate use improves pain or function. So we need to educate and set expectations that are realistic. We want to talk about tapering before we start them. We want to talk about tolerance and side effects. Often I see patients on opiates and loratadine or hydralazine because they have itching. Really, the itching and urticaria is often associated as a side effect of the opiate, something to remember. Low dose for the shortest amount of time, and important to really lay out how we are going to decide if it's working. Are we going to use that PEG scale? I'm always looking for improved function, improved ADLs, and quality of life. So if we're going to use opiates, and it's again our last choice because there are so many side effects and harms, and we see that so often these days, treating continuous pain with long-acting and sustainable release formulas is reasonable, but again, we want to plan out a out route for this opiate use. We want to plan our taper ahead of time. If someone comes on and I see them, they have oxycodone every 2 hours, PRN, this is not going to be useful. So then we add all up how many morphine milliequivalents we're using, and maybe we do MS Contin twice a day, again, with a plan for tapering. Then we can use up fast onset medications for PRN use. I never do Q 3 hours. I really don't use Q 4 hours. I try to do a PRN Q 6 hours, and I have a stop date for that PRN opiate prescription. Different opiates are similarly efficacious, so you want to use one with the least side effects for your patient and the cheapest. Again, no evidence that long-term use of opiates improves long-term pain or function. So what about these side effects for opiates? Constipation is a big issue, and tolerance to side effect does not occur. So we're always going to need a long-term laxative treatment when we are using chronic opiates. We can start with Senna, and then if we need, we can add an osmotic agent, but we don't want a bulking agent because it can cause fecal impaction. Nausea and vomiting often can get a little bit better with time and is more often seen with short-acting opiates. So what about sedation, fatigue, cognitive impairment? These all happen, and they're more seen in our patient population, in the frail elderly. So these can subside in a couple of days, and sometimes they don't. There's increased risk for falls and confusion and fatigue, and we really want to appreciate how our patients are tolerating opiates and whether this is the right medication for them. Respiratory depression is also obviously what we're so worried about with overdosing, and this respiratory depression is exacerbated with, of course, current use of benzodiazepine. This is a boxed warning from the FDA that we don't want to combine opiates and benzos for this reason. Okay. And when we start an opiates, we have to have an exit plan. We want it to be short term, and we want to look at the rest of our patient's medication list to see if they have any opiate potentiators. These are benzodiazepine, muscle relaxants, barbiturates, and gabapentinoids. And this will make the potency of the opiate that we start much more substantial, and the risk of overdose to be much more substantial as well. So we want to really take this into account, use a lower dose of opiates, and even more reason to taper the opiates off as soon as possible. So how much is too much? It's kind of an individual assessment. I stole this little chart, I believe, from Dr. Gom years and years ago, but I still really like it. But of course, you can go to the Oregon Pain Guidance Opiate Calculator and find out what is the morphine milliequivalence of the medications that you're using for your patient. And I gave you the link here, and you'll get these slides, of course, after we're done. We really want it to be, of course, less than 90 morphine milliequivalents per day, but we really would like to stay below 50 if at all possible. As it approaches your higher than 90 morphine milliequivalents, and you have maybe a potentiator like a benzodiazepine, your risk of overdose is significant. And so we want to prescribe naloxone when we're giving those high doses so that we can help patients if they become too somnolent. Another reason to find different ways to treat pain. So this is the most common scenario. My patient came here on this dose. I did not create this. It walked in the door, and that's what my patient was already on. What do I do now? So first, get a full history. How long has this patient been on this dose? Have they been taking it at home? How have they been using it? Have they been liberal with their PRN dosing? Have they combined it with other medications, maybe street medications? And is it working? I think if your patient comes to you with 11 out of 10 pain and is on all of these opiate medications, then we're not meeting this person's needs, and we need to find a new way to help. And so it really is an opportunity. If patients have been on opiates for a long time, they may have opiate use disorder, and then we have to be really cognizant on our next steps on how we're going to treat their opiate use disorder. If they've been on it for a short amount of time, but just have not had anybody to say we should think about tapering, then we can talk about this patient, talk about their fear factors, do things slow, and make sure that we're not going to say, so I'm going to take away your oxycodone and I'll see you in a month. That is not a good plan. We need our patients to know that we're in it with them, that we're going to be here for them, and I will support you through this. We want to monitor for cravings, of course, and withdrawal symptoms. I'm just going to touch about cannabis, but I encourage you to come to the CMDA conference because you're going to hear so much more. So Allison Villegas is going to take us with a cannabis panel, and we can really dig in deeper. But what I want us all to know is that our older patients are often using cannabis, and it seems like a really attractive alternative to opiates and other medications that seem to have more side effects. But our studies are limited for our patients over 60 years old, and we don't have a lot of evidence whether it works for neuropathic pain. The evidence for insomnia is very thin, as well as for anxiety. And so there's no real evidence also for persistent non-cancerous pain. So we're going to dig deeper into this in our annual conference, but I wanted to touch upon this idea. Also, our older patients are at higher risk for the adverse effects of cannabis, falls, cognitive impairment, and maybe some cardiovascular effects. Those are things we want to talk about with our patients. So we want to discuss the risks and benefits, know that CBD was deemed safe by the World Health Organization. There are some high quality studies out there, but we really want to partner with our patients so we understand what they're taking in the facility, outside the facility, and how can we make sure that they're safe and that we understand when we're adding medications, what they're already on. So what about opiate use with patients with renal failure? And these are patients that we really have to be cognizant on how we use opiates. We want to avoid morphine because its metabolites accumulate. Oxycodone and hydromorphone may be more safe for our renal patients, but again, these are dangerous medications that can be really addictive